Today we're going to be talking about asthma. Now, in preparing for this talk, I was again reminded that for every single topic in medicine, yes, the horizon is the limit. You can go extremely broad. There's so many aspects. There's a reason why someone can become a subspecialty pulmonologist, focusing only on asthma every day of his life, and still like not be considered the pinnacle of knowledge, because then there's subsets identifying specific things. So it's such a broad topic. So I think that in a single 1 hour session, you cannot do credit to this topic. But we are not intensivists, we are not pulmonologists, we are not internal medicine, we are the family medicine department. So my focus on this talk is not to be those things, but to be who we are. Accepting who you are is one of the first steps to healing. And so we are going to look at the family medicine perspective on asthma. So as I said, we are not going to be other things. We're not talking about the ventilations. We're not talking about acute exacerbations beyond the absolute basics. We're not looking at peds, because we don't see peds in Ward 5. We're not going to look at phenotypes and complicated risk factors and contributing factors much more than in the cases at hand. All right? What we will look on, and we'll spend a lot of time on, is perspective. It's one of the key issues in family medicine, about understanding your patient wholly and having your patient as part of a community of care, and having your patient as someone whose context you understand. So that is something which I think is often negated in asthma care, and so what I really like to focus on. Then obviously looking at diagnosis, looking at technique, and then looking at management approaches for our context again. So before any talk can really go on, we need to think about pathophysiology. And I'm sure some of you are amazing immunologists and can tell us all about the physiology, but that's not really what we as family physicians are going to be focusing about. So in a nutshell, what is the pathophysiology? It's, first of all, when you've got asthma, you don't have normal airways anymore. All right? So I like to relate things often to HIV. When you have HIV, then there's something that's part of you that's possibly there, that's probably there forever. The same way with asthma, you have got chronic airway inflammation. You're not starting with a base of a normal airway. Then you have triggers, and these triggers will cause bronchoconstriction and increased sputum production. That, in a nutshell, is asthma, all right? And I'm sure all of you know that. Now, you can get very fancy, and you can talk about allergic versus non-allergic, the type of allergic responses, adult onsets, or occupational, whether it's a eosinophil-mediated or a neutrophil-mediated, blah, blah, blah. It's not important for our context and for us here. Now, seeing that we've got students here who are so excited and ready for chocolates, can you guys help me with what are the common symptoms of asthma? I really am expecting full marks for you guys. There's 5 common symptoms. There's 5 chocolates up for grabs. Yes. Wheezing. Wheezing. Yes, that's one. Okay, no shouting. If you shout, you are automatically pulled out. Okay? Yes. Cough? Yes. All right, doctor? Dyspnea. So shortness of breath? Yes. Chest tightness? Yes. And Dr. Anya? Cough? It was already said. So variation, that's what I was looking for. So the 5 ones, according to the GINA 21 guideline, is wheeze, shortness of breath, cough, feeling of tightness, and variable expiration. All right, so these are the symptoms of asthma. All right, and so understanding the symptoms of asthma and being able to pull that from the history of the patient is so important in making an accurate diagnosis. Now, why is asthma important? Why are these symptoms things that you all know so very well? Well, we all know it so well because it's so common. Like asthma, that's a lot of zeros, guys. There's a lot of people with asthma. And more importantly than the zeros is actually the mortality. Annually, you're looking at half a million people dying with asthma attacks. South Africa, in context, we've got the 25th highest incidence of asthma in the world. But the problem is we've got the 5th highest mortality of asthma in the world. And that is really, really, really scary. And I hope at the end of this talk, at least for us in our population, that will not be the case, because there are some key tips and tricks and understanding that is required to prevent that. All right. Now, when you look at big numbers, there is one quote that is it always comes back to me. So Joseph Stalin said many, many things. One of them was this. The other thing he said is that all problem lies with man. When there's no man, there's no problem. But I mean, let's not go there. So essentially, when we're looking at conditions, no matter how common they are or how severe the potential sequelae if they're not well managed, it's still a number for us until that person has a name and a face. And so I think one of the keys in family medicine is trying to make it real, trying to take it home, trying to give this a name and a face. So looking at asthma, looking at names and faces that we might know, who do you guys think was the greatest doctor South Africa has ever had? Yes! So, Christian Barnard is like Mandela to politics is he to medicine in South Africa, no? And I mean, he died of an asthma attack on holiday. He was still doing quite well. And it was just said that he couldn't find his inhaler. And so you can be the greatest doctor, but if you have asthma and you don't have your inhaler, you're in trouble. All right. Now, to bring it home even more, we are going to have two patients that are facilitating this discussion. The first one is a 32-year-old male doctor with asthma. The other one is a 28-year-old homeschooling mom with asthma and some depression. All right. Now, let's look at our first patient. This is our young doctor who's had asthma since childhood. And that's all good doctors. He takes good care of himself, self-medicated. He's taking his inhalers. He's on an inhaled corticosteroid. He's had no recent exacerbations. And it's a bit of a pain that his girlfriend has a cat, because that he knows is his, his allergy. And so you are seeing this patient in Ward 5 in one of your consulting rooms. And this is what the patient looks like. All right. So, does anyone want to tell me what they saw in that video? Okay. So, well, we have a patient who's a male patient, and this patient is experiencing severe shortness of breath and an element of hysteria. All right. And so, what are you going to do when you see this patient? Okay, so you're going to give him an oxygen face mask, sure. Anything else that you would like to add with that? So you're going to give a nebulization, all right? And so we would give 1 ml of salbutamol with 4 ml of saline, 5 ml total. And then that is what we're going to give as a nebulization, because this patient obviously is not managing his inhaler currently. No? If you don't have a nebulizer, what are you going to give him? How are you going to manage him? You would use a spacer. Very good. So a spacer, you use 1 puff and then 4 breaths, and 1 puff and 4 breaths. Now, to note, salbutamol is 5 milligrams in a ml. Ventolin inhaler is 100 micrograms in a puff. So you can actually get to the same dose by using the inhaler and a spacer over time. So just because you don't have a nebulizer doesn't mean you can't manage someone who is having acute bronchoconstriction. All right. So this patient was given that. Now let's just quickly look also at what does the EDL say. So the EDL says, this is now what we say as a probable acute asthma attack. So the EDL says you need to look at the severity, all right? So let's not go into the detail of that, but you can identify this patient is not able to communicate, is completely out of control with his rest rate being much more than 30, is agitated, and I mean, I didn't have the pulse rate there, but we can presume it was high. And that patient will not be able to do a peak flow, all right? Peak flow obviously being key in all the initial assessments of acute shortness of breath, actually. How many of you have used the peak flow in your last assessment of shortness of breath? Yo, well done, guys. This is something which I've not done. I've worked for 15 years. I've never used the peak flow on a patient who's presenting with an acute shortness of breath. So really something that I think, me at least, I can improve a lot on. So this patient was given his nebulization, all right? And now you can see.
Really help. I need to go there. Thanks. It needs help. I need to go there. Keep waiting for me. Patients, big load. I just need to go out. I'll go home, take some steroids, and I'll be fine. I'll be fine. Thanks.
All right. So now this is post nebulization. So the EDL speaks about these as markers of severity. Né? So what do you think of him? He can't string a sentence together, né? Which is such a key thing. Even though he is a doctor, knowing the management, wanting to help you by seeing the cue, there's certain things that are, so like we as doctors like to look at numbers when assessing our patients, but sometimes we need to look at patients and look at basic things. So if you're not able to speak properly, if you're not able to complete sentences, then you're in trouble, all right? Even though he's smiling, even though he knows what he's supposed to be doing and wants to do something else, like this is a problem, all right? So we have a patient that we can't manage, and he's actually doing his peak flow. His peak flow now is 280, all right? So who wants to tell me, sir, do you think that peak flow is good? I mean, it's more than 100, right? It's 280. It's not good, né? So we need to think in context, because a peak flow of 280 for a 5-year-old might be really good, all right? But we're sitting here with a 34-year-old male who's 179 by my guesstimate. So there we go, which implies that irrespective of what the physician on call says about bed status, this patient needs an admission. This patient has a severe exacerbation. All right, it's not an outpatient case. Doctor, what do you do now? The management is fairly straightforward. I'm sure all of you have admitted patients with asthma exacerbations and have given them the IV steroids in cases where they're not going to be swallowing, have given them the ongoing nebulizations, have discussed them with the physicians, have given antibiotics, look for exacerbations, done the COVID spreads, etc. That's not the point of this talk, but identifying the patient is. And so knowing what the EDL says, and both in the primary and hospital level, for how to identify severe. Because as primary healthcare physicians, which family physicians generally are, our job is to identify the right people that needs to go to the next level. All right. So that's just for you guys to know about. Now, Simon, do you want to tell us what that felt like?
Pretty awful. They think we won the attack. So this is the kind of thing.
Yeah.
So it's pretty terrifying.
What I found remarkable was, like, I just asked him to act. And after the acting, he was like actually a bit out of it. Like he was like trying to just contain himself. And that's acting. All right. So looking at what people have described asthma attacks like, because I think this is key. You need to know what an asthma attack is like for you to understand the importance it is to get control. So these are quotes. I can't do anything but focus on getting oxygen into my lungs. I feel like I'm not in control of my own body. Now, those two, there was a reference made by one person of a type of thing which simulates this. And I apologize if you find this traumatic, but basically this is what that feels like. All right. So there's literally people that have made references to waterboarding when they have asthma attacks. All right? Because it's that absolute out of control, that absolute not being able to get oxygen, being desperately air hungry. All right? So like, this is used as a torture technique, but we are seeing people experiencing this on a day-to-day basis. Like, asthma is not a joke. I mean, other quotes from people who've had severe asthma attacks, it feels like someone is squeezing the air out of me. It feels like I'm breathing through a squished straw. Now, that squished straw has been used in multiple settings for identifying, for making people understand what it feels like to have an asthma attack. So everybody, you will see in front of you, there is some straws. If you wouldn't mind taking a straw and opening it, that table. If you need, there's more straws. All right. Now, one of the key things is not breathing through a normal straw. It's a squish straw. So just give it a nice squish in the middle there. Open your straw. We have a lot to go through, so Kawaleza. All right. Now, there's a thing which is called the straw test. All right. They want you to run on the spot. I don't think there's enough space for us to run on the spot, but let's try and do this with star jumps. All right, not start jumps, star jumps. That's autocorrect. Apologize. So take your straw, squish it a little bit. All right. All right. Now, everybody up, please. Okay, now breathe normally. All right. And I want you to jump 10 times. 1, 2, 3, go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. With the straw in your mouth. Now jump again. Thanks, guys. All right. Sometimes a change of perspective is what you need to see the light. If you know what someone else is experiencing or feeling, then you will have a better understanding of the importance of control. That to me is the family medicine perspective on asthma. Is there anybody that would like to say what they experienced? Who was there that was able to not take rescue breaths throughout? So everybody almost had to take rescue breaths throughout. Yeah? I mean, what are the thoughts in your minds? Like, oh my word, when is this stopping? Like, okay, I'm going to do this. I'm going to do this. No, I actually can't do this. I'm not getting the oxygen that I need. All right. And so this was a brief little example of what patients are experiencing a lot and for quite long periods of time often. And if you know what that feels like, when you see a patient and you ask about exacerbations, it has a different weight to it. It has a different importance in the urgency to get control and to not experience this, irrespective even of the effect on life, just the psychological effect of having that experience again and again and again. Okay, there's a reason why there's such a high amount of anxiety disorders in people suffering from asthma, because if you have had a couple of bad exacerbations, there will be emotional triggers, there will be physical triggers for anxiety symptoms because you have had such a traumatic experience. All right, so looking at what it feels like, let's now look through the basics of diagnosis and management, taking our experience now as the basis for why this is important. All right, so the diagnosis. The EDL says you need to have an improvement of 20% on bronchodilation. All right, so an asthma definition is a condition with classic symptoms and reversibility according to the EDL. And then they are using that as a cutoff. This cutoff is very, very, very different from all the international guidelines. The Gina before used to say, Gina is the Global Initiative for Asthma Control. They used to say 15%, but the latest is setting it at 12% variability. That's not a lot. So they're trying to say that, wow, if there is much variability, actually just treat it, because it's a very severe thing. And it requires for the diagnosis the history of variable symptoms. So we've spoken about what the symptoms are, those 5. The variation that you experience, trying to differentiate that from other things, because most other conditions that simulate asthma doesn't have so much variation. And then confirming the variable airflow limitation. Now, they have multiple ways that you can do it. Of note, the inter-visit variation on peak flow, as well as then your bronchodilation test, all right? So obviously you can check this in your own time, but the point is, if the patient has symptoms suggestive of asthma and your bronchodilation test doesn't meet the criteria, it doesn't mean it doesn't have asthma. There are more things to look at. Another one is you can literally give them mannitol or hypertonic saline and see if that worsens them, because that is a way to precipitate a bronchoconstriction, and then you see the airflow limitation. All right. Why is this important, especially in our context? Because how many patients have we seen, they've got the label of asthma and we just run with this label? There's no formal diagnosis per se made. Well, because you need to have a clear diagnosis before you commit someone to what's going to be a long-term treatment. But also in our context, we've got a lot of infective pathologies that can mimic asthma symptoms. And so they often don't have the variability. They will often, you can have patients come with a pneumonia with bronchoconstriction, but they don't have ongoing symptoms and ongoing variability. So it's not asthma, even though that label might stick moving forward and on discharge. Additionally, in poverty, restrictive disease predominates. All right. So there are some studies looking at how the lower socioeconomic and especially rural settings, there's less asthma because of an increase in allergen exposures. All right. So oftentimes poverty doesn't necessarily have a higher incidence of asthma. They actually, because of the smoke inhalation and, well, poor socioeconomic outcomes, they often have more restrictive disease. And so the idea is actually to not just have a peak expiratory flow, but to have a proper lung function test so that you can certainly say this is a patient who's got purely obstructive features and fits in the diagnostic criteria. So why diagnosis is important? An interesting fact is 2% of patients who are managed for asthma, this is in a study setting, actually had cardiac underlying pathology. For anybody who's want to be a eager beaver to diagnose for me what's on the X-ray on your left. It's even got little arrows to highlight it. Yes. What? No, what? But left. What does that mean? Yes. What do you think it's going to mean? That looks like asthma. Mitral stenosis. All right. So mitral stenosis classically has got. So mitral regurg is, ironically, if you're doing a lot of scans, you'll see mitral regurg are everywhere. Like 70% of you have mitral regurg. All right. And mitral stenosis is the big one that presents with cardiac asthma. And we often see it in pregnant patients, and they can actually get extremely sick and look exactly like a severe asthma attack. And that's the scariest thing, because then you're giving them IV labetalol to control them. And you're like, if I'm wrong, this is going to be bad. So just so you know about it. And then on the right is just pulmonary edema. Okay. But don't forget mitral stenosis. And the thing about mitral stenosis is the more severe it is, often the lower and softer the rumbling diastolic. And if a person is actively wheezing, you will not hear it. I have had 3, none of them you could hear it. I only picked them up on scan. You watch out for it. Okay. So the differential diagnosis for what can present with symptoms and signs looking like asthma is quite long. Of note for us is going to be PEs, which we do see a fair amount of. Esophageal reflux disease with aspiration. Then our ACE-induced coughs, they can actually present with wheezing. So it's just a thing to think about. And then lastly, obviously, we see a lot of cardiac failure. So these are just things to have in your periphery. There's a long list. Obviously, patient for patient, we're going to look at which things are applicable to exclude when they present with a possible asthma diagnosis. Now, the heart of this talk is the approach to asthma management. And there's, in my opinion, 4 key features that we need to pay attention to. All right. So looking at these approach features, we're going to go through a new patient. So a new patient, not Dr. Comley, thankfully, is going to be a 28-year-old female who's got fair insight and understanding and good inhaler technique. She's on a short-acting beta agonist, so that's a Ventolin inhaler as needed, and she's on an inhaled corticosteroid, a Becklite, the brown pump, 1 puff in the morning and the evening. All right. And there's a lovely little YouTube clip that she made explaining what her life with asthma is like.
I got my first asthma attack when I was 7, right in the middle of my school playground in front of 50 other kids. They thought I was dying. I did too. Back then, I didn't really know what was going on. It felt like someone was sitting on my chest with a load of 1,000,000 kilos. It felt like someone was hugging me so tight that I crushed my insides. My arms and legs felt like lymph noodles. It was almost as if I was breathing through a straw. I felt nauseous, faint, breathless, anxious, lightheaded, heavy, dizzy, weak. Feeling out of breath? Yeah, me too. The doctors told me some incomprehensible gibberish about how my airways were inflamed. The only thing that I could wholly comprehend was that my airways had mucus and I had asthma. At age 15, I was always accompanied with my trusty inhaler and medications. And of course, my omnipresent triggers. Dust, pollen, smoke, animal dander, and anything that made my heart beat faster than usual was a trigger. I taught myself how to swim though, despite my asthma. At age 20, I get an asthma attack while having sex. Sexy, I know. A vigorous cough takes over, and my lips and skin get a bluish tinge. My chest whistles, and I wheeze. All the breath had been sucked out of my chest. It wasn't so bad though, actually, especially when he held my hand and told me it's going to be okay. At age 25, I packed my bags and my inhaler. Always my inhaler. I hit the mountains when the city air gets too choked. It's happening more and more. Will I have to change my home to live, to breathe? I realize I'm not the only one. I'm 1 in 15 million.
So the 1 in 15 million is a reference to severe asthma. Okay, so this is our patient, sharing a little bit there. And she says that, well, I'm doing quite well. I was last admitted 5 years ago. So, things are going better than before. So how do you guys think we need to approach this consultation? You've got this patient, had a brief little narrative of how she's doing. How would you approach this consultation? Dr. van der Merwe, as the expert on asthma.
Well, I mean, obviously, the first thing going, what I would be interested in is how frequently it's a severe case, but I still want to know the frequency of what is short-acting beta agonist.
Yeah.
Just the baseline just to see how frequently some form of acute. Again, I have to admit, but still some form. Then get a gauge of the last stretch.
Your last words there help me to classify how to treat it. I think that is sort of the key, or part of the key. Yeah? KB is not here, but he said something which I like, which is you need to box your patient to unbox the treatment. I thought that was quite catchy. I like that. And so, we need to box this patient. We need to say, okay, well, let's look at where she is currently and then decide if she's at the right place for her. Now, looking at what treatment approach and treatment levels you have, let's go to what's the latest, which is the GINA 21. All right. And so this speaks about different steps. Yeah, you can see lots of information on the slide. but essentially it speaks about where the symptom control is. So start here if, né? And so if, for example, Dr. Comley was having his inaugural asthma attack and he's not had much symptoms before, then he would go to step 1. Whereas if Dr. Comley was, as he was described, with having fairly regular, although, you know, not regularly enough, we know our compliance is inhaled corticosteroid use, then he might have to go now to, you know, step 3, where he's will not be on step 3. So for this patient, nah, on what step is she currently? Any takers for chocolates? Well, looking at treatment. So we're not asking where she should be going. We're asking on what step is she currently. She on step 1. Medication, PRN with daily. So what? Where is she? Any other takers? Okay. So step 2 or step 3. All right. Depending on where, because remember, both at step 2 in most, including the South African guide, would not include steroid use daily there. Most would put steroid use daily at step 3. All right. So step 3 is where she would be. Now, when we look at asthma management, the first question is symptom control. All right. How do we assess symptom control? So Gina says, oh, you were too slow on the pool there. There's chocolates. You have to, all right. Gina says, this is how you look at symptom control, all right, which basically looks at those 4 key symptoms. Do you have daytime symptoms, nighttime symptoms? How often do you need a reliever? And is your life affected significantly? Those are the 4 key things. Now, the EDL actually recommends the asthma control test. It's actually in one of the appendices. For all my life, I have not been able to access that appendix. I was hoping to open up for us. I have it on my phone. I couldn't open it. Anyways, so we have an asthma control test, and we actually have an asthma control test on your tables. So who of you will help us to quickly do this asthma control test? There's chocolates for all participants. So looking at our patient, because there's no point just knowing about the test. You need to know how to do the test. And the interesting thing is you need to know how to take what the patient uses their presenting symptoms and make it applicable in the test instead of rephrasing the questions again and again. So you all see the test in front of you. There's our patient. Sorry. Another one. Here's one more. So will you guys quickly finish that test for me? 7 lying around here. And most importantly, she's saying, and she said to you, at least things are going better than before. So actually all the different questions are being answered here in what we have, all right? Oh, I can. All right, so the questions is, in the past 4 weeks, so it uses a 4-week interval, how much of the time did your asthma keep you from getting as much done at work, school, or home? Second one, and for all of them, it's all of the time, most of the time, some of the time, a little of the time, or not really. The second question is, in the past 4 weeks, how often have you had shortness of breath? Then in the past 4 weeks, how often did your asthma symptoms wake you at night? And then in the past 4 weeks, how often have you had to use your rescue inhaler? And how did you rate your asthma? So looking at this patient, the first question, any takers? How often did it get you to not complete your ADLs, your normal functioning at work, school, or home? So we said that she missed the work meeting. Ne? So there is at least some of the time. Ne? All right, so there'll be a 3. During the past 4 weeks, how often have you had shortness of breath? Now we said that she's using a rescue inhaler whenever she feels short of breath. So that is a lot of times. Okay, so that is going to be more than once a day. So that is going to be 1. So we're sitting at 4. The third one, in the past 4 weeks, how often did your asthma symptoms wake you up? And she said about once a week. Né? So that is going to be 3. So then we're moving to 7. Number 4, during the past 4 weeks, how often have you used your rescue inhaler? So we're saying you're using it daily. All right, many times. So that's 1. So that's going to 8. And the last one, how would you rate your control? And she's saying, well, it's somewhat controlled, probably. So we're looking at the score of 11. Now, when doing the asthma control test, a score of less than 19 means not controlled. Variations of 3 are clinically significant. So if you see a patient repeatedly and their score was 22 and now it is 23, doesn't make a difference. If it's now 24, it makes a difference. So variations of 3 is what you use for serial. And when a score is less than 19, well, what does that mean? It means that you do not have control, all right? And that is one of the key things in adjusting your stepwise approach to management. Now, medication. The EDL uses this classification, which is different to the levels, but essentially, mild intermittent is going to be level 2, mild persistence, level 3, moderate persistence, level 4, and severe persistence, level 5, okay? That's what we've just said. And when I first saw the EDL as compared to the GINA guidelines, I'm like, yes, why is South Africa always backwards? Huh? Why can't we just be up to date? But actually, the National Asthma Education and Prevention Program, which is the American standard, actually, they are on the same page as the South African standard. So they're still using a SABA as a standalone in your first levels and then a separate inhaled steroids. So looking at this, we have a patient that is on a low dose, all right, and that we are saying does not have symptom control. The keys, which is sorry, I just forgot to say, the keys which is different between the GINA guideline and the American and the South African guideline is they are saying you must add a steroid from the get-go. And the reason is because the newer understanding of pathophysiology is that there's ongoing chronic inflammation, which sets the asthma apart from normal airways. So that's why they want you to do it, because this low dose, the big trial which they did said that the inhaled corticosteroid, even if it is just on PRN use, reduces the risk of severe exacerbations with 2/3. So that is a massive risk reduction, which is why they want it. So even if you don't have the combination one, they would actually say if you're using separate treatments, you must use the short-acting beta with an inhaled corticosteroid whenever you feel short of breath. Yes, you have a question?
Is there a reason we're not doing that?
I think that the GINA 21 guideline came out in 21 and the EDL was 2019. So that's the first side of it. The second side of things is if you buy this in private, I'm speaking under correction, but I think it's about 275 Rand for this. If you buy an Ashevent, it's 35 Rands. If you buy this guy as a standalone, it's about 180 Rand. If I remember correctly from last time I had to buy for my family. All right, so there's a massive cost component. And there is obviously, this is a population-based thing. So you need, before they change the viral load cutoffs the CD4 cutoffs for starting ARVs, they needed to look at cost analysis. So for this patient, we need to look at what treatment step is she. So we are saying that she is got a steroid, but is this a low dose, moderate dose, or a high dose? Do any of you guys know what is sort of the differentiations between low, moderate, and high dose? I also didn't know. I was like, I've been working for so long, but I have no idea. Where do you go? I was at 1 puff, 2 puffs, and 3 puffs. That's sort of what I had in the back of my mind. All right. But it's not. Okay. Van Merwe, you're making an informed yes. Do you know?
No, I agree that I was counted.
All right. So we don't know, which is so important because there are ranges. And, you know, you need to box your patient. You need to say, well, this is, you know, step 4. This is step 5. We are seeing patients and we're keeping them in the same box, but we're saying we've increased treatment, but you need to increase them adequately to go to the next step. So this is actually how the differentiation is. So for our brown beclomethasone pumps, 200 to 500 a day. So essentially 1 puff morning, evening. If you're doing more than that, you're no longer low dose. 600 to 1,000 is moderate. So that means 5 puffs morning and evening is the upper range of moderate. All right. How many patients do you ever put on 5 puffs? We're like, no, that's crazy. You're not going to do that. But actually, that's in the guidelines for moderate dose inhaled corticosteroids. All right. For your budesonide, which is in your Symbicort, 200 to 400 micrograms, okay, a day in single or divided. So if you have a 329 and you're saying morning and evening, you're already beyond low dose. All right. So we need to know what drugs we're giving, and we need to know the steps that we need to escalate them. So this is a good reference point to take. Okay, I see there's photos happening. Take the photos and then we'll move on. All right. So for this patient, she was on a low dose beclomethasone, which is step 3. Going on, she needs a moderate dose. Now that can either be that we put her on a moderate dose combination, and you call that MART. That is maintenance and reliever therapy in one. All right. So the newer guidelines are saying you use this for both your maintenance and your reliever. Why? Because we know that giving steroids when you have symptoms is good for the inflammation, and because the long-acting beta agonist, which is formoterol, has an onset in less than 5 seconds, but a 12-hour symptom effect. So actually, it's much better than your short-acting beta agonist. Additionally, high use of short-acting beta agonists actually upregulates your responses. So you have poorer response in an asthma attack to beta agonist and increases your risk of severe exacerbation if you're using it more than once daily. All right. So looking on, we've not actually finished our approach to management. We've looked at medication, we've looked at control, but now one of the key things in the GINA is you need to identify who's at high risk of exacerbations, and you need to identify how to manage them early. All right, because failure of asthma management is a patient who ends up with death or admission. That is the endpoint you're trying to avoid. So how are you going to manage your exacerbation risk? There are 3 main components. The first thing is going to be, how do you identify risk? Who are at risk of severe bad outcomes in asthma? These are the risk factors. Now, looking through them quickly, poor control, as we've identified now with our asthma control test. There are many different tests, but essentially a person who's not controlled. Medications, so if someone has got poor technique or the incorrect step of treatment for their level of disease, but then also other medication that may precipitate asthma. For example, they're on a beta blocker, or there's non-steroidal use when they have a patient who's got known sensitivity. Exposures, so if you've got a person who has got an allergic reaction to formaldehyde, but they're working in a lab context, then you're going to have issues. If you've got a person who is allergic to animals, but they're working in the SPCA, you're going to have exposures. Managing your exposures is key to managing your risk. And if you've got a person who has got ongoing exposures that they're unable to get rid of, that is a much higher risk for severe outcomes. Context. You're looking at people who have mental health, specifically people who have known underlying anxiety disorders, have a much higher likelihood of being admitted for asthma. Part of that may be the overuse of short-acting beta agonists, but as a whole, that population group have a much higher risk. And then lastly, your context is socioeconomic as well. So lower socioeconomic have a higher likelihood of adverse outcomes when it comes to asthma management. Lung function looks at whether you've got structural issues. So obviously, if you've got a patient who's got post-TB, bronchiectasis is now on top of it all, their likelihood of severe outcomes is going to be higher. But also, if your FEV1 over FVC is less than 60% outside of an exacerbation, that is a very, very, very bad sign. Also, if you've got people who are doing peak flow and there's high variability outside of exacerbations, those are people who have a much higher risk of severe exacerbations. And the last risk factor is if you've ever in your life been in ICU for an asthma attack. So if Simon was in ICU when he was 6, even now at 32, it puts him at a higher risk for exacerbations that are severe. Or if you've had a hospital admission in the preceding 12 months. These are your main risk factors in our context. There are other ones like your eosinophil count in the blood, eosinophil count in the sputum, nitrous oxide levels in sputum. It's not relevant for our context, so let's not go there. Now, inhaler technique is an independent risk factor for adverse outcomes. Because I really want you to know how to do it well, I wanted to teach you guys and do a practical demonstration, but looking at time, we're not going to get to that. So if you are not sure how to do proper inhaler technique training, please talk to me afterwards and we'll quickly do one afterwards.
I suggest on Friday we make time in Ward 5 to do a little.
Yeah, we already have a difficult patient, so it's easy. Especially the switch. Yeah.
So actually, so let's make the booking for Friday.
Yeah.
We'll
Yes.
have some times and we'll have little groups of.
Okay.
As well as the vaccine.
So, looking at our patient now, she had poor control, which is an independent risk factor. And now, looking at home monitoring. So, who of you had done home monitoring before if you had asthma? So, it changes your life, by the way, okay? But so home monitoring requires obviously a peak flow meter. Peak flow meters are about £200, readily available. Governments are not issuing them stock standard at the moment, but I think that it's definitely an aspect that we should recommend our patients to have. So many trials have proven that it increases the compliance and reduces the risk of severe exacerbations if they have home monitoring. And home monitoring needs to happen in the morning and the evening because you want to see diurnal variation. And you are going to try and have a set point for patients where they have their reference standard. Their reference standard, ideally you want to do out of an exacerbation when they've already had preferably 2 months of steroids inhaled, all right? And no recent exacerbation. So they are pushing a lot for, you want your initial diagnosis to be clear and then a 3-month set point respiratory function, whether that be a full spirometry or just a peak flow. And then that becomes your set point. And then from there, you're going to do a diary. Now, if there's high, this patient actually has high diurnal peak flow variability, all right? Now, I wanted us to see when we do the peak flow, how much variability there is now. But again, we're out of time, we'll do that Friday. But this is a tool, and like all tools, it's only useful if you know how to use it right. So you as an individual can easily blow in it 3 times and get 3 different measures, all right? There's a lot of technique to it. So having variability in your documentation of home monitoring, you need to first and foremost know the patient's doing it right, all right? So it's an important thing to do. And then if you have got then your home monitoring, you need to have a written action plan. Now, this is something that's enormously emphasized, and I have yet to see us issue a patient with an action plan, all right? I have not done it. And so an action plan at its heart is saying, all right, you're doing the monitoring of yourself at home. Your reference number is going to be like Simon's case, 640. 80% of that, you're going to be looking at around 500. So anything more than 500, you're in the green. 500 to 300, you're actually in the yellow. You're in trouble. Your treatment needs to change there. It doesn't mean you need to come to a hospital. It means your treatment needs to change, and there needs to be a documented change in treatment. So like on this one, it says, use this medicine, how much, how often, and when to repeat your peak flow. If there is not a response, then you try it again. And if it's not a response, you go to a doctor. Or if it deteriorates in the red zone, you need to have an action plan. You need to know, these are the people that I will contact. These are the medicines I will take. And this is the closest facility that I will go. And this is my details. They know my details. That the medical alert bracelet, as is indicated, is obviously a nice thing to add on for patients. All right. So that is our approach of management, looking at medication, control, exacerbations, then lastly, management of triggers. Now, this patient actually mentioned all those triggers: dust, pollen, smoke, dander, exercise. These are actually the most common ones that people do have. There are myriads of more triggers, and it needs to be individualized. So I think it's important that each one of them you can go into and do some family practice, like how are you cleaning your house? What is your spring cleaning schedule for getting the dust mites out of your pillows? How are you managing animals? Can you get the animal to live somewhere else? Can you get a girlfriend without a cat? Are you going to, you understand? So there are things that you can do, all right?
That's what that, especially stuff like pollen, which tends to have like a yearly pattern.
Yes.
Are you allowed to change some?
Yes. Yes, absolutely. That is part of it. So if you have a person you know, we live in Richards Bay, the blue gum, the blue komboma, what's that correct with the well, I don't remember what bluegum in English is, but blue gum trees, they, eucalyptus, actually, they're called. They make pollen like nothing from August to September. And so all the sinus and all the asthma patients would increase their steroids from end of July through to October. Exactly that. Then beyond triggers for your patient, you need to look at non-pharmacological management. Now, non-pharmacological management is again a subspecialty almost in itself. There are so many things you can look at. Most importantly, you stop smoking, and that will include your own as well as secondary smoke that you're going to get in. So if your girlfriend has a cat and is smoking, you really need to look at finding an alternate person. Then other things that you can look at is healthy diet, because it facilitates healthy immunity, regular exercise, and exercise does not mean running. Exercise means sustained increase in heart rate. It increases your physiological reserve. It's going to increase your bounce back after exacerbations. And it's really, really, really good for you psychologically. So we want our asthmatics to exercise, but in a responsible and a safe way. Not all asthmatics have exercise-induced trigger, so they need to consider whether or not they need to preload them with medication or whether they can just go and if there's symptoms. Weight reduction, obvious reasons, avoid some medication. So just a small side note, you can start a beta blocker in conjunction with a specialist if the indications are there. So if you have a patient who has had asthma for a long-standing time, but now they've got cardiac failure, they probably need a beta blocker carvedilol. It's not something you do willy-nilly as an outpatient. That's something that you probably would refer and manage appropriately, but it can be done. Non-steroidal anti-inflammatories. In children, they generally don't exacerbate asthma. It's predominantly in adults, and it's quite rare, and it's specifically for people who have had a history of exacerbation. So they're saying you can give asthmatics non-steroidals. You need to warn them that it can worsen their symptoms. If it worsens their system, they need to come in, and then they need to say, I am non-steroidal responsive in my bronchoconstriction. All right, and then obviously your triggers that you need to manage. So as I mentioned, the risk of non-steroidals and beta blockers, but they can still be considered. Sorry for rushing through these last things, but unfortunately we're out of time. Thank you so much for your time. My hope is that we all will have a little bit of a better understanding on what patients experience, because my goal from this is not for us to necessarily review or change the guidelines, but understanding the importance of applying the guidelines efficiently and correctly for that patient so they don't have to experience these symptoms. Thank you.